Color invokes a visceral reaction in humans. We're very used to hues and tones that are commonly found in nature. We pay strict attention to atypical colors, and one of these colors is the color blue. And if a human, or any part of a human, is blue, then instinctively we know that something is wrong. Ironically, and this isn't the reason why we came to this conclusion, in certain cases of cyanosis, the best current treatment is one particular blue-colored dye. A couple different cases illustrate these scenarios. HD is a 55-year-old man in the intensive care unit on sodium nitroprusside, 1.5 mics per kg per hour for 3 days for severe hypertension and non-ischemic systolic failure. He's on ventilation support. For 7 days, he was sedated with IV lorazepam and phenobarb. Transesophageal echocardiography reveals good left ventricular function, and valves are okay. Baseline creatinine 3.4, urine output 20 cc's an hour. Exam is notable for cyanosis. He had an anion gap metabolic acidosis. Arterial blood gas shows mild acidemia, PCO2 31, PO2 119, and bicarb 13. Hemoglobin 8.3, but mixed venous O2 sat 43%. All of this means that his organs are starving of oxygen and can and will eventually fail if nothing is done. He has acute kidney injury, so why is this happening? Let's look at the cyanosis and the mixed venous sat of 43%. It's instinctive to humans that when we see skin lacking red hues, we know that something is wrong. And not just humans, we feel this way when we see it missing in other mammals too. Redness comes from the presence of bound oxygen to the iron moiety of heme, part of hemoglobin, in red blood cells. Notice that I said bound oxygen, because if we refer back to HD's arterial blood gas, we find that the PO2 of 119 is higher than normal. And this means that the pressure of oxygen is higher than normal in the blood. But if he's cyanosed with low oxygen saturation, it means that the oxygen isn't bound to the iron and thus cannot oxygenate tissue, leading to hypoxia and organ dysfunction. But first, is this really just a case of oxygen not being bound? And if it is, why isn't it bound? Well, let's try to answer the first question first. Based on the information given, we can construct a differential. From the top, sodium nitroprusside, SMP, look at the chemical structure, and what do you see? There's an iron, and then 5 cyanides. The name's right there, cyanosis from cyanide. SMP is well known to have the ability to cause cyanide poisoning. And how does it do that? Once the nitroprusside combines with hemoglobin, it releases the 5 cyanide ions. And the cyanide causes mitochondrial dysfunction by preventing the utilization of oxygen in the mitochondria. So cyanide poisoning is one thing that could be happening here because he's being given SMP. But why wouldn't it be this? 1.5 mics per kg per hour isn't that high of a rate, and anything under 2 probably won't result in cyanide poisoning. So we can likely rule out cyanide toxicity from the SMP. But let's continue. 3 days of nitroprusside is a little long. Cyanide is transsulfurated and it becomes thiocyanate, which is eliminated by the kidneys. HD had impaired kidney function, so thiocyanate elimination is prolonged, but it typically needs longer than 3 days to be toxic, and it doesn't produce low mixed venous sats. And it doesn't look like this. So there's more reasons for it to not be thiocyanate either. Lorazepam and phenobarbital for 7 days in kidney failure can lead to the accumulation of propylene glycol. He's got kidney failure, and that can cause acidosis, but it doesn't cause lower mixed venous sats. So this isn't it either. And this leads us to one more possibility. TEE is done with a topical anesthetic, benzocaine. And benzocaine always has a warning on the label of methemoglobinemia, and this explains everything happening to HD. Methemoglobin is when the iron moiety of hemoglobin is oxidized. This prevents the binding of oxygen and makes it so that the pressure of oxygen in the ABG is normal, while mixed venous sats are low and the patient is cyanosed. It causes the chocolate-colored blood that's observed because, in essence, you have a similar state of iron that you find in rust. How does benzocaine do this? Well, let's start with iron. The layout of the periodic table of elements tells us the energy levels of every single element. Each of the columns on the left and the right denote groups, and members of each group tend to exhibit some similarities with each other, while going along a row denotes an incremental increase in protons, and elements will tend to behave differently as you keep counting up. Iron is a transition metal. Counting upwards on iron's energy levels, nature says that we can remove 2 electrons and obtain some stability because that eliminates the 4th energy level. That's the iron 2 plus in normal hemoglobin, and it has the ability to bind to oxygen. When this form of iron gets oxidized to iron 3, it loses that ability to bind oxygen. And this is why the PO2 in the ABG is normal, but the blood is chocolate colored and not saturated with oxygen. But why does this happen with benzocaine? One particular metabolite of benzocaine is phenylhydroxylamine. Its electrons are delocalized. It's hydrophilic and it's unstable. It's reductive. Under the proposed mechanism as we know it today, it reacts with oxygen to become nitrosobenzene. The receiving oxygen becomes superoxide, which reacts with water, and this is where the iron in hemoglobin gets impacted. If you can remember back to your college chemistry days, one pivotal idea that gets introduced near the beginning of the semester and usually precedes a mass exodus of students in the course is the idea of resonance. The chemical is this, but it's also this at the same time. It's both of these things at once, but it also is still just one thing. You could say that it's a limitation of how we draw things, and that it's a limitation on how certain ideas end up getting depicted on paper. The idea that one thing can be multiple things simultaneously, but in reality is still actually only one thing due to the limitations of our own construction in the realm of depiction, is so deeply unsettling to some people that they change the course of their higher education because of this. And this concept applies directly to phenylhydroxylamine. In the setting of benzocaine toxicity, it is physiologically unsettling because nitrosobenzene is still unstable. It oxidizes to become phenylhydroxylamine again, and both of these species exist together at the same time, endlessly cycling between one another, shuffling electrons around, creating massive amounts of superoxide, and exerting heavy oxidant stress, reacting with iron 2 plus in hemoglobin, converting significant amounts of hemoglobin into methemoglobin, incapable of transporting any oxygen throughout the body despite oxygen administration. And given that this is a redox problem, then the antidote needs to be a compound that can restore iron 3 to iron 2. And the physiology of the red blood cell gives us some guidance. RBCs don't have mitochondria, so they rely solely on glycolysis for ATP production. Typically, methemoglobin does form on its own. There will always be some degree of oxidant stress inside the body. RBCs have a mechanism in order to overwhelmingly shift the balance in favor of hemoglobin. One of these mechanisms is glycolysis through the production of NADH that cycles through cytochrome B5 to transfer electrons. However, benzocaine toxicity will greatly shift the balance towards methemoglobin and overwhelms the cytochrome B5 mechanism. But another derivative pathway gives us even more insight. One branch from glycolysis is the hexose monophosphate shunt, which produces NADPH. From here is the production of glutathione, famously known to facilitate the metabolism of xenobiotics, especially acetaminophen, during the time of overdose. But it's not active in the case of benzocaine-induced methemoglobinemia. It's here where methylene blue comes in. Methylene blue accepts the electron from NADPH to become leucomethylene blue. Methylene blue is colored, but leucomethylene blue isn't. This electron is then passed on to iron 3 to restore iron 2, converting methemoglobin back to hemoglobin. And this reaction greatly shifts the balance back to hemoglobin because the methylene blue to leucomethylene blue conversion continuously happens through flavin reductase. No one needs to memorize these. It was proposed and discovered through a series of experiments. Methylene blue is tetramethylthionine chloride. It's a deep blue and has multiple uses, including aquarium treatment for fungal infections. It can also be used to treat parasite infections in fish. It can be used in staining procedures to examine RNA and DNA under microscopes. It has plenty of uses. This is where the resonance structure idea comes back. It does all of these things, and it can be a poison antidote in the body in this case. And it can be all of these things all at the same time. Remember that these ideas tend to diffuse out into the general world. HD's case is iatrogenic. I've previously described benzocaine toxicity on Chubby Emu in a video about a man misusing throat-numbing spray to eat spicy food at a competition, so something that happened outside of the hospital. And truth be told, until recently, most benzocaine cases were probably happening inside of the hospital. There was an aerosol spray that would be used on patients that was benzocaine, and there were plenty of methemoglobinemia warnings on them, until finally, at least for a while in my hospital, it became near impossible to get those sprays. But more commonly now, adult stores sell throat-numbing spray. These will have different formulations, so sometimes they won't have benzocaine in them, but there will be some that do have benzocaine. I did mention this very indirectly in the Chubby Emu video. Because benzocaine is a topical anesthetic, there could be misuse in other sensitive parts of the body. There's no limit to what you can choose to imagine here. Why would an adult store sell a throat-numbing spray? I'm not answering that, you answer that. And from that use case, can you imagine someone using too much spray? That's not a question. I'm telling you to take that situation into account. And when you do, now you know where a lot of inadvertent benzocaine-induced methemoglobinemia cases are happening from in the 2020s. If someone is unfortunate enough to have this happen to them, it's very likely that they're going to confuse the symptoms that arise as coming from choking or not breathing for some time. And that may be the case, but there's definitely a chemical component to it happening when it's taken like this. So for HD, different situation, same medicine, his antidote is methylene blue, administered intravenously, 2 mg per kg of real body weight over 5 to 30 minutes. Onset of action can be observed on the order of minutes, with maximum effects happening at 30 minutes. It's interesting, in the literature, especially back in the late 1920s and early 30s, there was a debate on the dose. It was very high at first, high enough to potentially cause methemoglobinemia itself. So there was some debate as to whether or not this was actually a treatment. Again, another resonance structure analogy. It can cure it, but it can also cause it. It's a paradox, but it also isn't at the same time. All of this discussion was around the time when it was being proposed as an antidote to cyanide. So methemoglobinemia is one cause of cyanosis, but it isn't the only one. Typically when there's ischemia, you can observe this color change. And there's one very sensitive part of the body between the legs in half the human population that performs its normal function because of blood engorgement, but can have ischemic emergencies. Priapism is a disorder in which the penis maintains an inappropriately prolonged erection in the absence of appropriate stimulation. That is, the stimulation never happened in the first place, or there's no natural detumescence following the male refractory period. Ischemic causes of priapism are an emergency because permanent damage to the tissue will happen, ending in permanent erectile dysfunction and permanent impotence. Priapism is categorized as either low-flow ischemic or high-flow non-ischemic, with flow referring to arterial flow. Very commonly, ischemic priapism is caused by hemoglobinopathies, mostly sickle hemoglobinopathies, and hypercoagulable states. Sometimes vasoactive medicines are known to cause priapism. In America, where we have direct-to-consumer advertisements for prescription medication, there were memes about the safety warning regarding erections lasting 4 hours or longer for erectile dysfunction medicine. So that's the word for those erections lasting longer than 4 hours, priapism. Interestingly, in post-marketing studies of these boner pill medicines, not the gas station ones, but the prescription ones, the incidence of priapism associated with Viagra, sildenafil, Cialis, tadalafil, etc., PDE5 inhibitors, is relatively low. Antipsychotics were more than twice as likely to cause it. However, the warning was put on the PDE5s because that was their primary purpose in this setting. You don't primarily take antipsychotics to induce an erection. However, priapism is also known to occur with cocaine. So, how does this happen? Blood engorges into the penis when smooth muscle of the tissues and arteries relax in the corpora cavernosa. Reversing this relaxation causes blood to flow out. This is normal function and maybe a little counterintuitive, since you might think that the muscles would be tense in this state. When blood is engorged for a long time, it's low flow. The blood becomes trapped, and some of it does still keep flowing, but it's painful. And while the smooth muscle is relaxed, the intracorporeal pressure increases, and there's a stretch in the tissue. This is now a kind of compartment syndrome, and without adequate blood flow, you get local hypoxia, acidosis, and ischemia. Does that sound familiar? You get cyanosis, one that isn't directly related to iron oxidation states like methemoglobin, but still a medical emergency nonetheless. PP is a 51-year-old man presenting to the emergency room with an erection for the last 36 hours. He tells the admitting nurse that it was induced following ingestion of tadalafil, cocaine, alcohol, and a penile self-injection of a compound containing alprostadil, papaverine, and phentolamine. He reported pain and difficulty passing urine, and he had a history of HIV, well controlled with medication. He did not have sickle cell, nor a history of erectile dysfunction. He was hypertensive, 161/104, heart rate 88, temperature 97. Ice packs were placed on the shaft with no response. Penile venous blood gas was remarkable for low pH, venous O2 sat of 8% with a high lactic acid level, all consistent with ischemic priapism. Following administration of local anesthetic, phenylephrine was given with minimal response. It was followed by administration of methylene blue, which did eventually result in a gradual day 2 mesence. So, what happened? This brings us back to arterial smooth muscle relaxation. In normal blood function, nitric oxide synthase makes nitric oxide, which works on guanylate cyclase to decrease smooth muscle contraction. This produces vasodilation, which is the issue in low-flow ischemic priapism, because we're talking about blood engorgement. Methylene blue inhibits guanylyl cyclase, providing a blockade of the pathway towards vasodilation, leading to vasoconstriction, which means in the setting of priapism, you no longer engorge the organ in blood, therefore no more erection. Phenylephrine right now is considered first-line therapy for emergent treatment of priapism, with methylene blue being a second line, as outlined in PP's case. But this mechanism gives us some insight. If methylene blue promotes vasoconstriction by way of limiting the mechanism leading to vasodilation, could we use it in another setting of abnormal vasodilation? Maybe. Sepsis is life-threatening organ dysfunction caused by a dysregulated host response to infection. There are immunological, hormonal, and circulatory abnormalities involved, and this can devolve into septic shock, which is a vasodilatory circulatory collapse that has cellular and metabolic consequences associated with a greater risk of mortality than sepsis alone. In the setting of septic shock, despite adequate fluid resuscitation, patients will require pressors to maintain a mean arterial pressure above 65. This is usually treated with aggressive fluids and antibiotics, and in the setting of shock, pressors. But sometimes, when there's refractory shock, methylene blue is given as salvage therapy with seemingly decent results for improving hemodynamic status, decreasing the length of ICU stay, and reducing the days on mechanical ventilation while possibly reducing some use of catecholamines. Mechanistically, methylene blue looks like it acts in a similar way to how it functions for priapism. At least in this setting, there hasn't been methemoglobinemia observed because while methylene blue is a fix for it, it can also cause it due to its electron withdrawing ability, which brings us to the other known adverse events associated with methylene blue. There's been a lot of buzz about methylene blue that I can remember going back to at least 2012. The US Health Secretary in 2025 was seen drinking it on an airplane. I don't have an opinion on it. The only one that I have is that if he doesn't need to put it in his body, then he shouldn't put it in his body. But maybe he does need to put it in his body, and that's great. But if he doesn't, but he still wants to, more power to him. Back in 2012, there were websites that I remember coming across where people would advocate for drinking methylene blue as a sort of antioxidant for all the environmental stresses that happen in your body. And again, my opinion on all of this still hasn't changed one iota. If you don't need to put it in your body, don't put it in your body. And maybe in the last 10 years, coming from around 2015, there's another combination therapy that you're going to see get thrown out there, methylene blue and red light. So this is something purported for depression, bipolar. In the more extreme usages of this, I've seen people in dark rooms wearing goggles, shining the light directly on their anus. If you're healthy and you have no health problems, I really don't see a point in doing this, anus or not. Even in the psychiatry world, this is at best going to be a non-standard approach. And this brings me to one adverse event that can happen with methylene blue. This has monoamine oxidase inhibitor activity. It's not solely that, as we've been talking about this entire video. This was demonstrated experimentally and after a 2011 FDA announcement of methylene blue being involved in serious CNS reactions when given to patients taking serotonergic medicines. The resulting serotonin syndrome has been documented to be fatal. It's possible this MAOI activity is part of the reason why people will claim that they clear out their brain fog after taking methylene blue. But on the flip side, for other people, it might be why they feel really unwell with headaches after. Don't forget, MAOIs also have a drug-food interaction, so foods high in tyramine, cheese, cured meats, fermented foods, soy, wine and beer, pickled and dried fish, and not limited to these, can potentially cause hypertensive crises when consumed with methylene blue. So if you've taken this as a supplement before and had negative side effects in line with headache, lightheadedness, nausea, etc., it may have been a food interaction. No guarantees, but again, take only as absolutely necessary. This is one part of why we don't really use MAOIs as medicine now anyways. And on the flip side, there's no shortage of people taking serotonergic medicine. So I wouldn't say that this AE is negligible. And it's a black box warning issued by the FDA. Do you remember this diagram about how methylene blue works with NADPH? Well, sometimes people have a deficiency of glucose 6-phosphate dehydrogenase as a genetic disorder. This would mean that they don't produce adequate NADPH, which would disrupt the action of methylene blue in theory. And the thing about G6PD is that there's over 400 variants of it, and it's impossible to know who has what. And regular cells may still be able to convert leukomethylene blue, which may still be able to make its way into the blood. So there's two strategies here. One is to not give it if the patient has methemoglobinemia and tests positive for G6PD. Give them a blood transfusion instead, and if in the case it looks like they might not make it, then give them methylene blue as a last resort, hoping that it'll allow some of the infused RBCs to use their NADPH. One strategy here is to administer it at therapeutic dose and see if there's an impact on methemoglobin levels. If there isn't a response, don't increase the dose because there's a risk of hemolysis, in part because of the electron transfer happening in the absence of NADPH. If it doesn't work, then hyperbaric oxygen or exchange transfusion would be the alternative treatments. One interesting correspondence that I found was from 1989, where methylene blue was commonly used to diagnose premature rupture of the membranes in pregnant women. It would be injected into the amniotic fluid and then get into the vagina. The problem is, sometimes the baby will come out blue because of the dye. They can have hemolytic anemia and hyperbilirubinemia, but sometimes the baby itself will just be blue from the dye. And this would make assessment of hypoxia difficult because pulse oximeter can't be accurate due to the discoloration. So treatment of this patient was complicated simply due to the fact that the baby was dyed blue by a blue dye. And because premature infants can have respiratory distress, it makes it even harder to treat them properly. The final thing that I want to talk about goes back to the cured meats and not wanting to eat high tyramine foods if you do supplement with methylene blue. Cured meats are prepared with sodium nitrite. Now, in the Chubby Emu video associated with this episode, I described a sodium nitrite accident, and the cook thought that she was using sugar instead. This was published in literature in 2013 and led to a change whereby food-grade sodium nitrite is typically dyed a color to distinguish it from salt and sugar. The dye in this particular product was not banned by RFK Jr., the US Health Secretary in 2025, because the FDA announcement preceded the presidential inauguration that year, so this ban was something that was already in the works well beforehand. Nitrite induces methemoglobinemia in a similar fashion as benzocaine by shuffling electrons incessantly and inducing an oxidative stress. But unfortunately, at the end of the 2010s, people were obtaining it from the largest online retailer in the United States to do things to themselves. The New York Times reported on this and tried to get that retailer to act on this. Now, I don't know everyone's individual and household situation, and unfortunately, you may never actually know when you might need it, but knowing that methylene blue is an antidote to this particular poisoning, which is physically identifiable due to the cyanosis that happens, it might be useful to have some on hand just in case. I don't sell it, and also IV is the ideal route of administration in a clinical setting in this poisoning. And so having it on hand for regular folks will then mean that we're talking oral use. And this is just a recommendation. It's for a last-ditch effort, no other ideal outcomes possible situation in the case of absolute emergency where seconds and minutes absolutely matter. Speaking of Priapism and throat-numbing spray, there's another substance that's maybe adjacent to some of these concepts called poppers. These are alkyl nitrites. They're inhaled, but sometimes people will drink them. And what happens when you ingest nitrite? That's right, methemoglobinemia. Methylene blue was first theorized as a cyanide antidote. What's interesting is that in terms of treatment, very quickly, it was found that sodium nitrite was a better antidote to cyanide. that is inducing methemoglobinemia for cyanide to bind to the iron 3, and then sodium thiosulfate is given to form thiocyanate, making the cyanide less toxic, and which was in the differential for patient HD at the beginning of this episode. All of this has fallen out of favor against hydroxycobalamin, which is a form of vitamin B12 to treat cyanide poisoning. And that's an in-depth on methylene blue and methemoglobinemia. It's a poison antidote in a very specific case, and it's second line or salvage therapy in an adjacent matter. If you're perfectly healthy with none of those issues, you may not want to put it in your body if you don't need to put it in your body. If you zoom out from everything that I said in this video, it is truly bizarre that one fix to someone becoming blue in the face is one particular kind of blue dye. Thanks so much for listening. Take care of yourself and be well.